Hello and welcome. Good afternoon and welcome to Allergy Insider. And my name is Scott Duhaime and I'm the host for today's program. I'm one of the clinical educators with Thermo Fisher Scientific and a physician assistant here in South Texas. And I'm joined today with my colleague, Derrick Varner, who's also a clinical educator with Thermo Fisher Scientific and a physician assistant here in South Texas. And we're also behind the mic today, and behind the camera we have Jordan Lilly, who's going to be monitoring the chat bar and for any questions that we might have, and we encourage you to put in any questions. So before I get started, I want to mention that the intent of today's program is for medical information, but medical information as just general medical information, and is not intended to be utilized as specific medical education for a particular disease state for you. If you watching today have specific symptoms or any concerns with your own medical situation, those questions should be addressed to your medical provider. So that said, today the program is focusing around answering the question, why are my allergy medicines not working? And so, as you can see out here today, it's spring and everything's pollinating, and so people have a cascade of symptoms, and those symptoms can be just what you would think most of the viewers on Allergy Insider would have: that rhinitis or runny nose, that congestion, that sneezing, that postnasal drip. And most of the folks on this program are going to be taking medications to try to alleviate that. But sometimes those medications are not working. And because they're not working, it makes folks want to go ahead and seek out care. So let's start that conversation with Derrick. So Derrick, why don't you, say if a patient comes in to see you asking that very thing and complaining about that very thing, saying my meds aren't working, how do you approach that for those patients?
Well, great question, Scott. I would tell you there's like 60 million individuals within the United States are somewhat plagued with this condition. And one of the things that I always start with is what I call the bedrock of medicine, which is to take a good history. Good history, right? Listen to the patient to see what symptoms are they having, which you mentioned, right? With the itchy eyes, the itchy nose, the runny, sneezing, coughing, congestion, things of that nature. And then I would incorporate a good physical exam. Right? Take a good physical exam and determine what other clinical clues that may help us to determine, is it allergic or non-allergic? But the key thing is listening to the patient. When did the symptoms start? Where are they sort of having the symptoms? Is it at home? Is it at school? Or is it in an environment, indoor, outdoor? So we need to elicit that history. And then, if need be, we may need to consider maybe some type of testing, if need be.
Okay.
Yep.
Oh, great. Well, great. In testing for those causes that could be allergic versus non-allergic. Now, you mentioned the non-allergic.
Yes.
Those non-allergic causes.
Right.
Kind of unpack that for our viewers today. Okay. What are some of those common non-allergic causes?
Right. Great question. Another thing is when you talk about rhinitis, no pun intended, but we're under a canopy, the umbrella, right? I like using that analogy. When you talk about rhinitis, I like to put things in buckets. So you got this, some things that are very common, some things that are less common, and then there's some things that are rare that I would typically refer my patients to you for. And so underneath the common, because we don't have a lot of time, those are 4 areas I like to cover. The first one is what we call vasomotor rhinitis, which is not allergic. And also in that category is what we call idiopathic, meaning that we just don't know what it may be. Because if we do testing and it's not allergic or it's not allergy driven specifically, then it's maybe idiopathic. We may not really determine or find out the cause. And then there's something called gustatory, or what we call reflux induced rhinitis, which is chemical rhinitis, and which involves, it can be tobacco, it can be the temperature changes, it can be pollutants in the air, it can be perfume, it can be a host of things, paint, aerosol sprays, etc. And then we have gustatory response. And you know what, Scott? We're in San Antonio, Texas, and right about now there's something called Fiesta, Texas, that's going on, or Fiesta. And so sometimes with that gustatory reflex response or rhinitis, that involves when patients like myself, we like eating hot, spicy food, and sometimes if you are above age or adult age, you can partake in adult beverages. Sometimes the alcohol may cause that response. And then there's an occupational rhinitis. Depends on where you work at. There may be certain things that you may be working with that may cause that response. And then lastly, the infectious rhinitis, which involves viral or is it bacterial?
Yeah.
So those are the 4 most common things that we consider when we talk about rhinitis.
Oh, great. That was a great rundown for that. Thank you for that, Derrick. You're mentioning all these common causes of non-allergic rhinitis, and it makes me think, how do we treat these? I mean, are all those treatments about the same? Are they the same as allergic rhinitis treatments? And kind of break that down for us a little bit. How do we treat these?
Yeah, that's a good question. There's a lot of literature out there, and because what we said before, there are different etiologies or different causes. And so each cause may require a different treatment plan or involve different things. And so let's just take, for instance, that vasomotor rhinitis, which is, I go locally. I go topically with the intranasal saline.
Yeah.
Sometimes I even tell patients to take a nice warm shower, right, to irrigate those, and also maybe use a neti pot. Some of the other things that we may prescribe is the intranasal steroids, intranasal antihistamines, and also if it's more what we call secretory or maybe rhinorrhea or runny nose, I may use something called ipratropium bromide that may help kind of stop it. But also, because a lot of patients, Scott, they may present with this congestion and this bogginess, and so sometimes I may introduce for a very short period a nasal decongestion for a very short period of time. And so that's for the vasomotor rhinitis. But when it comes to the gustatory reflex, the things that I enjoy, right, I may just encourage the patients to maybe avoid those irritants and those triggers for the most part. And then, of course, with the occupational, we also may have them avoid some of those triggers, along with maybe some of the saline washing and sprays and things of that nature. But most important, maybe have them wear a mask or even a respirator. But at the other end of the spectrum, if they've done all that, they're still not getting the response, one of the things that we may tell them to do, we may have to change occupations. And so for the 4th most common treatment plan, we have to determine if it's viral. If it's viral or infectious rhinitis, those are usually self-limited. They go away over a short period of time, maybe 7 to 10 days. They get better by themselves. And of course, we treat them symptomatically. So sometimes I may give them an antipyretic like a Tylenol or ibuprofen to kind of help if it's they have a fever or any pain that's associated with some of those other things. But of course, I will tell you this, and I see this quite often, when those patients sort of swing over to that bacterial phase and it goes beyond like 3 to 4 weeks, sometimes I may have to get like a CT scan to do a further evaluation to look at those nasal passageways and those sinuses.
So great. Great. So there's other causes, and then there's other treatments other than the traditional allergic rhinitis. And as you were saying that, I was thinking a patient came to mind. I remember this one patient not too long ago, and this patient that fits into the category you're describing, where they maybe had something in their environment that was causing symptoms, but it wasn't allergic. Let me tell you this real quick. So what happened was we had this child who was seen in the clinic and was having symptoms at one home and not having symptoms at the other home. So the parents were separated, and the child was having symptoms at the mother's house, but not at the father's house. And sure enough, the primary care provider went ahead and did some testing and did the testing for the patient for allergies, and all of the allergy results came back negative. Everything was negative. And so the concern was, well, there must be something at that mother's house that's not at the father's house, and we thought it might be dust mites or something causing those symptoms, but in reality it wasn't that. What it was upon further investigation, it was noted that at the mother's house, the mother was lighting those scented candles, but lighting more than 1 or 2. She was lighting those scented candles all throughout the house. And as we know, those scented candles produce particulate into the air, and enough of those to get into the air and inflame a patient's airway, nasal airway, causing a cascade of symptoms that look exactly like the allergic symptoms. So it's just what you're saying, exactly what you're saying on that. That it wasn't an allergy, looked like an allergy, but it was something in the air, some type of particulate, just like Derrick was saying. So great, thank you for that. So and now that I'm thinking about it, what about those patients that maybe have a little of each? What about those patients that have a perennial year-round allergens and have problems, and then this time of the year we got things pollinating, and maybe they have a combination of causes? How do you address those patients?
So good question. I would tell you that there's a lot of literature out there, but one particular study comes to my mind, Scott, and it was dealing with where patients were self-presented themselves as having those allergic symptoms, they report allergic symptoms, and we as providers, we've given them those oral antihistamines. And what it was shown was 2/3 of those patients were not allergic. Those symptoms were that they thought were attributed to those things that were in the environment weren't really allergic. And so because of that, there's a chance those patients that have that propensity, right? They can have a strong family history. They may be genetically predisposed to that. Plus, they may have other exposures that they may become sensitized to. So you can have a combination, or what we call a mixed rhinitis, right? So it can be non-allergic along with allergic. And because of that, because of that accumulation effect, one builds off the other, right? It's a cumulative effect. Yeah. And so sometimes there's something called a symptomatic threshold. Everybody has a different level. And that level, what we call that symptomatic threshold, is once those symptoms or that inflammation continues to occur based upon those things that we talked about that are very common, and also allergies, once they get that level, that's when they become symptomatic.
Gotcha. Yeah.
So you can have both.
Yeah.
A mixed rhinitis, which can be non-allergic and also allergic.
Yeah.
Yes.
Great. So,
yes.
So what I'm hearing you say is that you can have those patients that have a little bit of each,
yes.
and it just adds upon itself. And once it adds up to a point where it reaches their threshold, their bucket is full, and now it's spilling over, and they're seeking their care.
Exactly.
Outstanding. Great.
Exactly.
Well, I think you've covered everything really well. You've given us a great rundown of the allergic or the non-allergic causes, and also the combo when those are together, and the different types of the most common types of non-allergic, and some of those treatments, which is great, and I appreciate that. Why don't we go ahead and see if we'll check in with Jordan real quick to see if there's any questions for us before we.
No questions thus far, y'all.
All right,
Okay,
great.
good.
Thanks, Jordan.
Good,
All
good.
right, great.
Well, if there's no questions, but I do have one question for you, Scott.
Sure.
Because I know Scott has worked some time in nose and throat, otolaryngology. So when we talk about some of those common, less common as some of those rare things, have you seen in your experience those patients that have presented that look like allergy or even non-allergic, but they had some other anatomical issues going on that you noticed?
Great. Thanks for that question, Derrick. So in ENT, we'll see, and quite often, otolaryngology, ENT, ear, nose, and throat, what we'll see sometimes is patients that are failing on their primary care meds for their symptoms. And sure enough, they see their primary care folks, and they've done a great history and physical, like Derrick has described, and there's either some suspecting some kind of obstruction in the nasal airway, or they're just failing their medications, and a further detailed physical exam needs to be accomplished. And some of the most common ones that you would think of are patients who have a majority of their symptoms are congestion. They may also have some rhinitis and may have some runny nose in the back or in the front, some postnasal drip, but the majority of their symptoms are going to be more of just an obstruction. They can't breathe through their nose, or they're having poor sleep at night, which is a secondary effect of not being able to breathe through your nose. And some of those common ones are one is that most folks think about is turbinate hypertrophy. Now, if you look inside someone's nose, they have a turbinates in there, and those turbinates are little fleshy outpouchings inside your nose. And what can happen with those is through chronic rhinosinusitis, just rhinitis or rhinosinusitis, just chronic inflammation can cause those to hypertrophy or get big and block up your nose. Now that should go down over time or with some medications, but sometimes in some patients they stay chronically inflamed and chronically large, and there are some procedures that we can do in ENT to kind of reduce that turbinate hypertrophy. Other ones include, of course, other ones that include are nasal septal deviation, and that can be mostly on one side versus the other, but it can be on both sides, and causing the same exact symptoms. Also, chronic rhinosinusitis with some polyposis, meaning polyps, which is just a fleshy, non-cancerous growth that grows inside the nose, and those can block up the nose as well.
Yeah.
So, great question on that. And those are surgical repairs for all of those, too.
Yeah. Hey, Scott, let me ask you this. As you were talking, one of our patients came to mind. I'm not sure if you had this experience, but have you ever had a foreign body that a patient presented with, this chronic nasal congestion, rhinorrhea, and you go to look inside, you do a physical exam, and what do you see?
Oh, yeah, you see something that, especially with kids, we see that a lot with kids where, they have a chronic rhinitis, and usually that's going to end up being colored and thick because it's going to be part of an infection too. But they've been treated, they've been done everything you can, and unfortunately kids like to stick things up their nose, and
Yes.
it happens quite a bit.
Yes.
That we'll do is we'll get into, especially with the pediatric ENT folks, we can get in there, we can get that out of their nose, and that can be anything from a little bean, a little toy, or even sometimes
marble.
paper, marble, anything
Right,
like that.
right.
Because it's an interesting place to stick something. So kids love to stick stuff up there.
Right,
All right,
right.
Thank you for that question, Derek.
Good,
I'm going
yeah.
to check back in with
Yeah,
Jordan
let's
real
check with
quick, see
Jordan.
if there's any questions for us. Go ahead, Jordan.
Yeah, so y'all, we have a question that came in the chat. Are there any foods that trigger allergic rhinitis?
Yeah.
Yeah.
Go ahead and talk about the
Yeah,
books
so
that you're using.
we talked about that fell into one of the most common rhinitises, and that's the reflux-induced rhinitis, and underneath that is, along with chemical rhinitis, there's something called gustatory. And so there are some foods that will cause that localized response, that secretory, or what we call rhinorrhea, right, the runny nose. And like I said, I'm here in San Antonio. One of the things I enjoy is enjoying some hot, spicy food. Sometimes I do indulge a little bit, not all the time, but adult beverage, some alcohol. So those things that can cause that response that may do that. And so what we do is we just encourage the patients to either diminish the amount of intake of that item or that trigger, or completely eliminate it.
Yep.
So you don't have that symptoms.
Okay, and let me just add one thing on to what Derek was just saying. That is that foods in and of themselves can be part of a cascade on a systemic, meaning anaphylaxis. Like if a patient is having anaphylaxis from a food, they will have a systemic response, and they can have some rhinitis in conjunction with that.
Right.
And even with the oral allergy symptoms, where your patient can have a food and have a little itching around the mouth, they can have some nasal. But food in and of themselves causing an allergic response is pretty rare. It's a rare thing, and it's not commonly thought of. Now, a response that Derek's talking about is not an allergic response. That's just a response from the food itself, which is different than an actual allergic response. A great question. Thank you for that, Jordan.
Thank you all.
Yeah.
We have one more.
Yeah.
Someone in the chat asked, is there a difference between reflux itself and chemical sensitivity?
Okay, so if I understand it, the question is there a difference between the reflux-induced rhinitis and also chemical? So I think there is a distinction per that, because the chemical can be what we mentioned earlier. It can be the aerosols, it can be the candles, the particulates in the air. It can be from tobacco. It can be from those are what we like to put them in that I call the bucket, right? As far as the chemicals, a larger list of anything. And so as far as the other one, what was the other question?
Reflux.
Reflux.
Right? Yeah.
Gastrointestinal.
Yeah, so like acid reflux can annoy the back of your, when you feel that reflux coming up, sometimes it's silent too, but that can annoy the back of the throat, and as well as come up all the way up to the nasal pharynx and the posterior nasal pharynx in the back, and cause inflammation. And as a result of that, similar symptoms that Derek's describing here, where you can end up having rhinitis. And so there's a distinction between those two in answer to the question.
And because of that, Scott, I think it goes back to the bedrock, right, of medicine. That's why we have to, as providers, we got to listen to the patient. We got to listen to that history. We got to ask those certain questions and do what we call a review of systems, to ask particular organ system questions that kind of help us guide us to determine what is what. Because those symptoms are what? Overlapping.
Absolutely.
And they can be complex and complicated. And so, but that's why we encourage you definitely get back with your primary care provider and ask those questions so we can figure things out.
Okay. Yeah, great. Thank you. Thank you again for that great rundown and that great background. Sure. Any other questions that we have today, Jordan?
Not this far.
Okay.
Thank you all.
All right. I think we'll go ahead and wrap it up then. And by wrapping it up, I want to just say that let me ask you, you wrap it up first, Erica. What advice would you have, anybody watching this right now who heard everything that we just discussed, what advice would you have for those folks listening to our discussion today? What are their steps if they're experiencing this?
Yeah, I would say, Scott, some of the things I would encourage you to do as viewers out there, first take an inventory of your own health history, your symptoms, and begin to jot those things down, because sometimes we think we remember, but before you go, just take a little note. Note when, where, how, what makes things better. Also, take a note of what medications have you tried that worked and then did not work, right? So you take all that information, make an appointment with your primary care provider, and then if you failed even all of the over-the-counter medications, along with the prescriptions that they're giving you, and then if it is allergic, they may suggest, you know what, we've done all that we possibly could do. Let me send you off to an allergy. Let me get an allergy referral because you may need immunotherapy. Also, if it is non-allergic, then we may need to send you to someone like Scott, who works in the ENT specialty, because there may be some things that are non-allergic that may be anatomically or structural challenge that they may need to assist with for the non-allergic. So once again, this is where that shared decision making comes in, and this is where you talk to the primary care provider, you work with them, and then we decide to figure out what is the best treatment plan for you.
Outstanding. So if you're not, just to back up what Derrick just said, if you're not experiencing relief in your symptoms in your from wherever you are year round or this time of year, go to primary care folks, give them a good history of what's going on, and they can either increase your meds, change your meds, or send you to somebody to figure out why you're failing those medications. So with that, I'll go ahead and wrap up the program real quick and say that please look forward to the next time you see the advertisements on Allergy Insider for the next program. We'll have one next month as well. And on top of that, we'll if you have any other questions or want to take a deeper dive into the issues Derrick and I were talking about today, there's a couple of websites, the Thermo Fisher websites that are out there that give great detailed information that further go into everything we've talked about, whether that's Allergy Encyclopedia or Allergy Insider. You can get on those real quickly just by getting on, just Googling that into the chat bar, into the Google bar, and search those out. And with that, I'm going to go ahead and end the program. And thank you very much for being behind the camera today, Jordan. And thank you very much for being our guest today.
Thanks,
Appreciate it.
Appreciate it.
All right,
Yes,
you all take care, and we'll see you next time.
See you next time.